Thyroid Trivia. Megan Chan, PGY1. UCMC 2015. Diagnosis of thyroid disease includes 3 aspects: functional aspect, pathological aspect, anatomical aspect. Example: euthyroid Graves' disease with goiter. http://witwinhow.com/wp content/upload/2012/08/TMP602F42_thumb22.png. Hyperthyroidism definitions. What is the difference between thyrotoxicosis and hyperthyroidism? Thyrotoxicosis equals elevated T4/T3 that may be due to a variety of reasons, for example synthetic ingestion, thyroiditis. Hyperthyroidism equals elevated T4/T4 from the thyroid gland. What are the common causes of hyperthyroidism? Graves' disease, diffuse toxic goiter -80%. Plummer's disease, multinodular toxic goiter -15%. Toxic thyroid adenoma, single nodule -2%. If transient, Hashimoto's thyroiditis, subacute thyroiditis, early stage. Plummer's disease equals hyperfunctioning areas that produce high T4 and T3, rest of thyroid is not functioning, atrophy. Non-thyroid causes of thyrotoxicosis. Thyroid carcinoma, exogenous hormone, high datiform mole, choriocarcinoma, excess TRH, TSH-oma, pituitary T3 resistance, struma ovarii, thyroid destruction, hyperemesis, TSHR mutation, familial gestational hyperthyroidism, amiodarone, INF-alpha-induced, HIV treatment, sunitinib therapy. http://www.thyroidmanager.org/chapter/diagnosis and treatment of Graves' disease/thyroid exam in hyperthyroidism. Guess the diagnosis based on the following thyroid exam. Thyroid exam. Diagnosis: diffusely enlarged, non-tender. Graves' disease. Diffusely enlarged, tender. Subacute thyroiditis. Bumpy, irregular, asymmetric. Plummer's disease. Single nodule within atrophic gland. Toxic adenoma. Hypothyroidism definitions. What is primary hypothyroidism? What are some examples? Failure of the thyroid gland accounts for 95% cases. Hashimoto's disease, chronic thyroiditis most common. Iatrogenic, radioiodine Texas, thyroidectomy, meds, for example lithium, amiodarone. What is secondary hypothyroidism? What is deficient? 2 have pituitary disease. Deficiency of TSH. What is tertiary hypothyroidism? What is deficient? 2 have hypothalamic disease. Deficiency of TRH. What are other causes of hypothyroidism? Subacute hypothyroidism. Increased TSH production maintains T4WNL. Subacute thyroiditis, late stage. Blood work. What is the best screening test for thyroid disease? TSH. Always repeat TSH before starting Texas. TSH in severe illness, steroids. Why is obtaining free T4 helpful? T4 is helpful to see if TSH is inappropriately normal, for example pituitary cause. When should you obtain T3? Concerned for subclinical hyperthyroidism, can have T3 thyrotoxicosis. Iodine deficient diet, body makes T3 instead of T4. Conditions associated with transient free T4. Explanation: estrogen withdrawal, rapid decrease in TBG level, amphetamine abuse, possibly induced TSH secretion 2, acute psychosis, unknown, hyperemesis gravidarum, HCG, can cause thyrotoxicosis, iodide administration, thyroid autonomy, beginning of T4 administration, delayed T4 metabolism 3, severe illness, rarely, decreased T4 to T3 conversion 4, amiodarone treatment, decreased T4 to T3 conversion, iodine load, gallbladder contrast agents, propranolol, large doses, inhibition of T4 to T3 conversion, prednisone, rarely, high altitude exposure, possibly hypothalamic activation, selenium deficiency, decreased T4 to T3 conversion. http://www.thyroidmanager.org/chapters/diagnosis and treatment of Graves' disease / blood work. What AB tests are positive in Graves' disease? Thyroid stimulating AB, TSI. 90%. TSI binds TSH receptors on surface of thyroid cells and triggers synthesis of excess thyroid hormone. TSI also binds tissues in the eye and skin, exophthalmos and pretibial myxedema. Thyrotrophin receptor AB, TRAB. 90%, high specificity. Antiperoxidase/microsomol AB, TPO low titer. Greater than 95% of PTS. Antithyroglobulin AB. 50% of PTS. What AB tests are positive in Hashimoto's disease? Antiperoxidase/microsomol AB, TPO high titer. 90% of PTS. Nonspecific 5 to 10% of healthy people test positive. Blood work. What does thyroglobulin do? Makes T4/T3. When do you test for thyroglobulin plus antithyroglobulin binding AB? Testing for lack of thyroid tissue, for example SP resection or ablation of thyroid cancer. Test in patient who might be taking exogenous hormone, as thyroglobulin is suppressed in this case. What does thyroid binding globulin, TBG, do? Binds T4 and T3 reversibly, making them inactive. Free T4 is not influenced by TBG. Increased in pregnancy, hepatitis, OPCs, ASA. Decreased in glucocorticoids, nephrotoxin, cirrhosis, androgens. Imaging. What is a radionucleotide uptake scan most helpful for? Helps identify the cause of hyperthyroidism, diffuse uptake, Graves versus patchy, Plummer's disease versus hot nodule. No real use in euthyroid or hypothyroid patients. Usually need to remove hot nodules, no remission. When should you order an ultrasound of the thyroid? If you see a goiter. If you feel an enlargement or thyroid nodule. What are signs of a malignant nodule? Benign if nodule less than 1 mm. Malignant, greater than 2 mm, irregular borders, calcifications, papillary, blood supply via Dopplers. If multinodular, can perform radionucleotide uptake scan to determine which one to biopsy. Hypoechoic equals lots of blood. Imaging. If a benign appearing nodule is found, what is your next step in management? Monitor with repeat use in 6 months to 1 year for 2 to 3 years. If remains stable, can increase the interval. If a malignant appearing nodule is found, what is your next step in management? FNA or resection. FNA is incorrect 10% of the time, false plus or false. Pocket medicine, 4th ed. http://intranet. dmu. edu. http://internat.dmu.edu/data/cafdris/internal/med/lic/pt/n/internal%20 medicine/04%20 hyperthyroidism.%20 pathology%20 of %20 parathyroid%20 glands.htm. Pocket medicine, 4th ed. http://endocrine.surgery.ucsf.edu/media/5095649/thyroid_scan.jpg http://www.advancedonc.com/wp-content/themes/royal/images/ultrasound-guided-fna2.jpg Hyperthyroid treatment, pharmacologic. What is the preferred treatment for hyperthyroidism? Methimazole inhibits thyroid hormone synthesis. Once-a-day med, agranulocytosis in 0.5%. What is the second-line agent and when is it used? PTU, propylthiouracil, used if allergic to methimazole or first trimester of pregnancy, risk fetal anomalies. Inhibits conversion of T4 to T3. For both methimazole and PTU, what labs should you check? LFTs, WBC, TSH. Tinamides, methimazole, PTU. What agents do you use for acute treatment of hyperthyroidism? Beta blockers for SXS control and partially inhibits T4-T3 conversion. Sodium ipodate or iopanoic acid are iodine radiocontrast media that acutely lower serum T4 and T3 levels by preventing release and peripheral conversion. Lugol's solution, iodine salts, inhibits synthesis and release of thyroid hormone plus size and vascularity of hyperplastic thyroid. Used for thyroid storm and in preparation for thyroid surgery due to rapid onset of action, 2 to 7 days, and transient effects, several weeks. Thioamides equals methimazole and PTU. Amiodarone can cause hypothyroidism by blocking peripheral conversion of T4 to T3. However, it can also cause hyperthyroidism through an iodine-induced mechanism in persons with underlying thyroid disease, for example multinodular goiter, or through an inflammatory mechanism that causes leakage of thyroid hormone into the circulation. Treat amiodarone-associated hypothyroidism with thyroid hormone. Iodine-associated hyperthyroidism with thioamides. Inflammatory-associated hyperthyroidism with steroids. Thioamides equals methimazole and PTU. Thiocyanate, SCN, and perchlorate, ClO4, block uptake of iodide into thyroid gland. However, rarely used clinically due to unpredictable effectiveness and risk for aplastic anemia with perchlorate. Lang Pharmacology, 10th ed. Hyperthyroid treatment, non-pharmacologic. When is radioiodine 131 used? Elderly with Graves' disease, solitary toxic nodule, Graves' disease that fails medications, recurrent thyrotoxicosis. Thyroid cells are the only cells in the body that absorbs iodine. Contraindicated in pregnancy and breastfeeding due to risk of cretinism. Greater than 75% become hypothyroid. When is surgical subtotal thyroidectomy performed? Mostly used in those with obstructive the goiter. Very effective but rarely used, only 1% of PTS, due to high risk of side effects. For example, permanent hypothyroidism, recurrence of hyperthyroidism, recurrent laryngeal nerve palsy, permanent hypoparathyroidism. Hyperthyroid treatment. Why is it important to treat Graves' disease? If untreated, increased risk for systolic HTN due to increased CO and osteoporosis. In Graves' disease, only 20 to 25% go into remission spontaneously in the U.S. Should you treat subclinical hyperthyroidism? No evidence to treat subclinical hyperthyroidism unless TSH less than 0.1 or symptomatic. Progresses to overt hyperthyroidism till the 15% in 2 years. Hypothyroid treatment. How do you treat hypothyroidism? What is the starting dose? Start levothyroxine at 1.6 micrograms/kg/day. Can start at lower dose, 0.3 to 0.5, if increased risk for arrhythmia, for example AFib, or ischemic heart disease. May need increased doses with pregnancy, 30% bivacate, estrogen replacement, poor GI absorption, concomitant Phe or Ca, PPI, sucralfate, celiac disease, IBD. How long does it take to see effects? When should you recheck TSH? Start to see effects in 2 to 4 weeks. Recheck TSH and free T4 in 6 weeks. Why is it important to treat hypothyroidism? If untreated, increased risk for diastolic HTN due to stiffened arteries and hyperlipidemia, LDL, HDL. Should you treat subclinical hypothyroidism? Treat subclinical hypothyroidism if TSH greater than 8.0 to 12.0 or of symptomatic. Progresses to overt hypothyroidism till the 4% per year.